Now, in terms of what causes mood disorders, we can draw on what's called the biopsychosocial model that includes an array of predictors. In this case, biological factors, which refer to things like hormones and neurotransmitters, psychological factors, which include cognitions, beliefs, memories, and motivations, and social factors, including the treatment from others and expectations. In addition, how we treat mood disorders can also draw on the biopsychosocial model in the sense that each of the treatments we can develop will target one of those three levels. So if we want to target biological factors, then we'll try to help the brain with prescription drugs such as Prozac or Zoloft. If we want to target psychological factors, then we'll try to help the mind with things like cognitive behavioral therapy. And if we want to target social factors, then we'll want to help the environment by doing things like family therapy or community programs. With that in mind, let's look at some of the specific factors and treatments for both unipolar and bipolar mood disorders. The general lifetime prevalence rate for major depressive disorder is over 15%. In other words, about 3 out of every 20 Americans will meet the criteria for major depression during their lifetime. The 12-month period for persistent depression, the proportion of people who meet criteria during a 12-month period, is about 0.5%, or 1 out of every 200 people. The average age of onset for unipolar mood disorders is in one's mid-20s. So this is not something typically experienced by older adults, although women are more likely to experience depression compared to men. In fact, in Europe and North America, the odds are 2 to 3 times higher for women than men. The good news is that for depression, recovery is very common. Generally speaking, recovery begins within 3 months for 40% of individuals and within 12 months for 80% of individuals. However, relapse rates are also high, with 40 to 50% of individuals experiencing a second major depressive event at some point in the future. Additionally, of the individuals who experience a major depressive episode, 5 to 10% will later experience a manic episode and then be diagnosed as having bipolar 1. There are also comorbid disorders across the lifetime commonly experienced for people with depression. 60% also experience an anxiety disorder, 32% experience an impulse control disorder, and 24% experiences substance use disorder. The lifetime prevalence rate of bipolar disorders in the general US population is estimated at approximately 4 to 5%, with bipolar 1 constituting about 1% of this rate. Comorbidities include 65% of people with borderline personality meet the diagnostic criteria for at least one additional psychiatric disorder, most commonly anxiety disorders and substance use disorders. Unlike with depression, we do not see a significant association between the experience of bipolar disorder to race, ethnicity, gender, or socioeconomic status. This suggests a stronger genetic and biological predisposition to bipolar disorders. Symptoms typically start in adolescence. Longitudinal studies show that those diagnosed with bipolar prior to adulthood experience a worse outcome relative to those with an adult onset, including more episode recurrence, higher rates of suicidality, more extreme social, occupational, and economic side effects. Research across family and twin studies does show that genetic factors are implicated in the development of major depression, but no single genetic influence has been identified. Stressful life events and early adversity are environmental factors that play a role in predicting depression. This can include significant relationship difficulties such as divorce, economic instability such as unemployment. Early adversity such as childhood abuse or neglect is also associated with increased risk of depression. Attributional styles also play a role. This is a general tendency to perceive, interpret, and recall information. People with pessimistic attributional styles tend to make internal, global, and stable attributions. So, for example, someone, if they fail an exam, might think it was their fault, therefore internal, that they are stupid, global, and that they will always do poorly, stable. And this person with a pessimistic attribution style is more likely to experience depression over someone who sees the failure as being caused by a lack of studying, which is more specific, and that they can try again and do better next time, unstable. As for risk factors for bipolar, genetics play an even bigger role here compared to depression. That is, bipolar disorders are even more strongly heritable. We see a higher correlation between twins and biological siblings compared to adoptive children. We also see environmental factors playing a role. Particularly severe stressors such as loss of significant relationships can adversely impact the onset of bipolar disorder. Ironically, positive life events can also adversely impact the course of bipolar. Why might that be? Well, people with bipolar suffer more manic episodes after life events that involve achieving a desired goal. Finally, we also see evidence that stressors which disrupt sleep or the daily biological routines that train our circadian rhythms, like meal times, can also trigger episode relapse. Studies have shown that life events which involve a disruption of sleep or daily routines, such as overnight travel, can increase bipolar symptoms in people with bipolar disorder. The earliest antidepressant medications were monoamine oxidase inhibitors, or MAOs. MAOs inhibit enzymes involved in deactivating dopamine, norepinephrine, and serotonin. They can have serious side effects, though, including dangerously high blood pressure if taken in combination with certain drugs like antihistamines or eating foods with amino acids commonly found in cheeses, wine, and soy sauce. Tricyclics, the second oldest class of antidepressant medications, block the reabsorption of norepinephrine, serotonin, or dopamine at their synapses, resulting in increased availability. Tricyclics are the most effective for treating vegetative and somatic symptoms of depression, but they also have serious side effects, the most concerning of which is toxic effects on the heart. Selective serotonin reuptake inhibitors, or SSRIs, and serotonin and norepinephrine reuptake inhibitors, SNRIs, are the most recently introduced antidepressant medications. Generally, these medications are less cardiotoxic, less lethal in overdose, and produce fewer cognitive impairments, but they have their own side effects, which include but are not limited to sexual dysfunction, gastrointestinal issues, and insomnia. There are several biological treatments for people with depression, especially medication-resistant depression. Options include electroconvulsive therapy, or ECT, transcranial magnetic stimulation, or TMS, and deep brain stimulation. ECT involves inducing a seizure after a patient takes muscle relaxants and is under general anesthesia. ECT is viable for patients with severe depression and show resistance to antidepressants. A common side effect is confusion and memory loss, usually short-term. This is a very uncommon treatment today. Repetitive TMS is a non-invasive technique administered while a patient is awake. Brief pulsating magnetic fields are delivered to the cortex, including electrical activity. TMS has fewer side effects than ECT, and thus may be a promising treatment for patients with MDD who have shown resistance to other treatments. Deep brain stimulation involves implanting an electrode in the brain, and the electrode is connected to an implanted neurostimulator, which electrically stimulates that particular brain region. There is limited evidence supporting this treatment, and more research is needed. Psychological treatments typically consist of therapy, and as we discussed in previous videos, cognitive behavioral therapy has the strongest evidence base to support its efficacy in treating depression. These therapies primarily focus on helping patients identify and change distorted automatic thoughts and assumptions, and are based on the rationale that thoughts, behaviors, and emotions affect and are affected by each other. Interpersonal therapy for depression focuses largely on improving interpersonal relationships by targeting problem areas such as unresolved grief, interpersonal role disputes, and life transitions such as the transition to parenthood. Family therapy often works by involving significant others, parents, and other family members into the therapy process. Medication is also an important part of the management of bipolar disorder. Lithium has strong efficacy, but a number of side effects also that can make lithium treatment difficult for patients to tolerate, including things like impaired cognitive function, as well as physical symptoms such as nausea, shaking, weight gain, and fatigue. Because of the difficult side effects, medication adherence is a major barrier to the treatment of bipolar disorder. Anticonvulsant medications, such as the others listed here, are commonly used to treat patients with bipolar disorder, either alone or in conjunction with lithium. Other treatments for bipolar disorder include interpersonal and social rhythm therapy. This aims to increase day-to-day smoothness in patients' lives and encourages vigilance in maintaining a stable rhythm. The therapist and patient work to develop and maintain a healthy balance of activity and stimulation, such that the patient does not become overly active, like taking on too many projects at once, or inactive by avoiding social contact. The efficacy of this form of therapy has been demonstrated in that patients who receive this treatment show reduced risk of episode reoccurrence and are more likely to remain well. Now, a brief note here about SSRIs. SSRIs have exploded in recent years as a method for treating depression. And this is in part due to the fact that their side effects are relatively mild compared to the other medications we have studied, and it's a more efficient treatment compared to psychotherapy, which is often more costly and time-consuming. I also want to bring this to your attention because I'm sure that at least some of you are taking SSRIs now or have previously taken or might someday in the future take them, but they are not without controversy. First of all, 1/3 of those treated with antidepressants like SSRIs do not improve. And among those who do improve, a significant proportion of them will get a little bit better but still remain depressed. This is known as a lack of clinical significance if someone still suffers from a mental illness despite some moderate improvement. Second of all, even if they do work for some people, we still don't know why. There's no model for mental illness that suggests a, quote, chemical imbalance in the brain, such as not having enough serotonin or dopamine. If that were true, literally everyone who starts taking an SSRI would immediately feel improvements. But SSRIs take weeks on average to show an effect. There is no optimal level of neurotransmitters in the brain, so it is unclear what would constitute an actual imbalance, nor is there any evidence for an optimal ratio among different neurotransmitter levels. Although some SSRIs, such as Prozac or Zoloft, appear to alleviate symptoms of severe depression for some people, there's evidence for at least one serotonin reuptake enhancer, or SSRE, that is also effective for depression. The fact that SSRIs and SSREs could both have a positive effect suggests that we should seriously question the validity of a chemical imbalance model in the brain. Moreover, for the past few decades, scientists have been searching for evidence that a genetic predisposition to low levels of serotonin would predict susceptibility to depression. The specific gene identified was serotonin transporter gene 5-HTTLPR, but this has been debunked. There is no evidence of a link between genes regulating serotonin and the experience of depression. As I mentioned earlier, the biopsychosocial model suggests that biological treatments should be clearly linked to a biological cause or predictor of illness, but so far we have found no such clear link. Finally, some new research shows that lifestyle changes, including more exercise, change in diet, mindfulness meditation, and quality sleep, are just as effective as SSRIs for treating mild to moderate depression. So in summary, I know that many of you will have taken or are currently taking SSRIs, but you should know that the science behind these medicines is shaky at best, and we still don't understand whether they work for the average patient, how much they're effective, the mechanism by which they would work in the brain, as well as any long-term negative side effects.